This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to geripal.org/CME.
And on to the show. Welcome to the GeriPal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, we got a great topic today. I can't believe we talked about palliative care in the emergency room. We haven't really talked about integrating geriatrics or integrating specific programs in the emergency department for vulnerable older adults. But today we do. Alex, who do we have with us to talk about this subject?
Well, I talked to Liz at the Beeson meeting in D.C. a few months ago.
Liz,
and
who?
She was like, I haven't been on the GeriPal podcast. And I was like, you're right. That is shocking. And you absolutely should be on the GeriPal podcast. So I'm so glad to welcome Liz Goldberg, who is emergency medicine doctor and researcher and associate vice chair for research at the University of Colorado and past president of the Academy for Geriatric Emergency Medicine. Liz, welcome to the GeriPal podcast.
Thanks so much for having me. Excited to be here.
And we are delighted to welcome Lauren Southerland, who is also an emergency medicine doctor and researcher and director for clinical research at The Ohio State University. Lauren, welcome to the GeriPal podcast.
Glad to be here with all of you.
So we got a lot to talk about integrating programs in the emergency room for older adults. But before we go to that topic, Lauren, do you have the song request for Alex?
Actually, I do.
Oh, Liz has the song request. I should have wrote that down. What's the song?
It is Gravity by John Mayer, and it's because I love everything falls prevention, and Gravity is just, it's wicked.
Yeah, that's good.
Alex, you just did Gravity and Wicked, right?
What's that? Well, last week we did Defying Gravity, so we're kind of on a gravity kick here.
We are.
All right, here's a little bit. Gravity is working against me, and gravity wants to bring me down. Oh, I'll never know what makes this man, with all the love his heart can stand, and dream of ways to throw it all away. Gravity is working against me, and gravity wants to bring me down. I got to stop or I'll just go on forever. I love that song. Great choice, Liz.
All right, Liz, I'm going to start off with you. What got you interested in older adults in the emergency room, integrating geriatric principles? Like, where did this come from?
Yeah, happy to tell my origin story.
Yeah.
I worked at a busy level 1 trauma center in residency, and we did these 24-hour shifts that were pretty grueling on the trauma service, where we saw all the ED patients that came in for serious injuries. And one thing that irked me as a resident on that service was we would see so many patients come in with falls, and it felt like there was so much variation in care. Sometimes we would admit them for maybe this was syncope. Sometimes they were discharged. We almost never figured out what their etiology was for their fall. And then we would see them back. But next time I was on call, it was like a 72-hour call situation or 24 hours, and I'd be back on 72 hours later. And I was like, we need to do something about this. So I walked up to our case managers and said, what do you think we need to do for these falls patients? And they had just done this audit, and they had learned that they really needed PT services in the ED. And that would be so helpful because we would be able to identify functional impairment and lower extremity strength issues. And so I dreamed up this study that involved having patients that come to the ED for a fall, seeing both a physical therapist to kind of address those things, that I listed, and then a pharmacist to look at polypharmacy and fall risk increasing medications. And like lo and behold, the intervention worked. We were able to reduce recurrent ED visits for falls by 66%. And that was one of our first, and actually it was the largest US trial to date in falls prevention that was randomized. And we recognized it was really valuable to have PTs and pharmacists in the ED to help us with these older kind of complex patients. And since then, I think we've just seen a huge uptick in embedding services in the ED for these vulnerable older adults.
And it had a catchy title. What was the catchy title?
It's GAPcare.
GAPcare. What does GAPcare stand for?
It stands for the Geriatric Acute and Post-Acute Fall Prevention Program, and not post-acute like sniff care, but really thinking about if we can help with their transition of care out of the ED back into the community, give them a good falls prevention plan, then they won't have to come back.
Okay, I want to go back to GAPcare, but I want to hear a little bit more origin story because I want to hear Lauren's origin story.
My true origin story was I was in college, wasn't going into medicine, and was sitting next to a friend who was super smart. And he said, I just took the MCAT this weekend. I'm exhausted. And I said, you're like this amazing physicist. Why'd you take the MCAT? And he said, because I looked at my professor and thought, I don't ever want to be that guy. And so I looked up and thought, I don't want to be a pure researcher either. I want to be around people. So I got into medicine, and then I found that the patients that no one else cares for are the older adults. I really take more of a systematic approach to it, looking at how we provide acute care to all our patients, which works very well. You know, if you're 30 years old and you need your appendix out, the ER is fantastic at that. But if you are 70 and you're feeling weak, or you're not sure if it's a medication or what's going on, these patients sit in the lobby for 8 to 10 hours. They miss doses of their home medications. We have a lot of areas we need to improve on their care. And the ER can actually cause more harm than good sometimes for them. So my work is focused on how do we create an ER environment that provides the care these patients need when they need it. Because they definitely need the ER a lot. They need that acute care.
Yeah. How much, like in your daily life, how much of is it that acute care, like you're seeing people in the emergency room that have like a new pneumothorax, pneumonia, MI, stroke, trauma, versus more like they kind of need a really good primary care provider, or a home-based primary care, or a social worker, or man, if they just saw a physical therapist and a pharmacist 2 weeks ago, everything would have been fixed.
Yeah, I think, and Liz can chime in on this too, I think we see the whole range of patients. We see those who have excellent care, good social support, they have resourced for all their medications and things, and a great primary care doctor, and maybe they're coming to ER because their cancer's worse and now they're vomiting or something else that could not have been prevented. But I also see a patient to shift who's an older adult who has a lot of comorbidities and is very social economically vulnerable. Maybe they're unhoused. Maybe they have no social support or family caring for them. Maybe they have alcohol use disorder, and we're like, oh, they're just drunk, send them back on the street. I was working on a patient the other day, like the sign out was, he's drunk. When he sobers up, send him back home. I'm like, okay, but he's unhoused. He's like, yeah, social worker will get him a, lift somewhere. And I said, well, look at this person is older than 60s. They're an older adult. They're using the ER very frequently. It's almost always either a mental health problem, a substance abuse problem, or a cognitive impairment problem. And we searched his chart and he'd never had any cognitive testing. So when he sobered up, we do a cognitive eval, and this person had, severe dementia or some sort of cognitive impairment, probably from his long-term substance abuse. There was no way they could get to housing on their own or remember what you said. And so they needed to be admitted for legal guardianship. And that would have been missed if I didn't have a bigger viewpoint on what are the needs of these vulnerable older patients.
Eric, to your point, there's at least 1, 2, sometimes like half of the patients in your shift that need that look that Lauren is talking about, of someone that hopefully has additional qualifications beyond what we're trained in emergency medicine residency training to expertly handle these acute issues, but to dig a little further, talk to a care partner, engage some of these embedded services, and then you can stop this cycle of folks coming back in over and over again. And we don't always have that cognitive bandwidth or really the time or even the beds to do that. But the ideal care would represent doing what Lauren did. Thinking a little bit more about, well, what, if this person is coming back, that should trigger, like what I teach the residents is if this is a bounce back, if this is someone that has recently been in the ED and has gotten the same care that you provide today, who in their right mind would think that they wouldn't come right back and do exactly what happened last time? So it's about stopping that cycle and getting the patient what truly they need that they may not even be able to express.
How do you think we do that? Like, I just look back to my days when I was like ward attending. I was a terrible palliative care doctor, despite actually being a palliative care doctor at the time. When I'm on palliative care service, I thought it was pretty good. But when I'm ward attending, I got everything else that I'm trying to do that it's so hard to find the time to do what I usually have on the palliative care service or even like on the geriatric consult service. Does that seem like similar in the ED for you? And if so, like, what's the solution there?
Yeah, so I think we're at the point where we're finding those solutions, and it is these multidisciplinary care teams. It is not making that ED doctor be the only one thinking about these issues.
Do better, ED doctor.
Exactly. Ideally, it would be doing what Lauren described in her manuscript of like, there's people that are really good at figuring out social services for folks. It's not the ED doc. It's probably not the ED nurse that is carrying 6 patients at the same time and treating someone with sepsis and stroke. You really need to sometimes pull in this additional expertise if you want to stop that cycle.
Lauren, tell me about this manuscript.
Why, yes, sir. I will tell you about my research. I think what Liz has identified is that the emergency department is run incredibly leanly. We do not have any extra capacity in our staff. We're often understaffed. You often don't have enough nurses or techs. Asking people to do more is difficult. It also isn't an even flow. So, yes, you might know that this patient probably needs a full hospice and palliative care discussion. The last hospice discussion I had was at the front door of the ER as the patient and their family were walking out from the waiting room because they'd waited too long. And so I had to chase after them and tell them that their triage x-ray showed worsening cancer and discuss like, hey, I'm really worried about how you function at home. They said, well, we know she's going to die. We'll just bring her home to die. I'm like, okay, well, let's get hospice involved. And so I'm doing this at the front door of the ER. Not the right place, not the right person. We need more capacity. And the way to bring in that capacity is to ask your administration to hire more staff. No, I'm joking. We know that's a lie. No one's getting more staff. So
what do we do?
We have to leverage what we have and make it so that these patients are a priority, because we know that if we start interventions from the emergency department, we reduce those downstream falls, re-ER visits, rehospitalizations, and we know we reduce the hospital rate. So if anybody's at a hospital that's always operating at or over capacity and aborting patients in the emergency department, these are the kind of mentions they can look at to stop this cycle and help these patients. So we've done several things, bringing physical therapists down to assess people in the emergency department rather than waiting for them to be admitted and seeing them a day or two later. Front-loading those types of evaluations can be incredibly helpful, and sometimes they can avoid the admission altogether. Another project we did at OSU was partnering with our County Office on Aging. What we found was that our hospital case managers, and most emergency departments have hospital case managers already, would see a patient, say, oh, you would qualify for these county services. You might do better if we had some home-delivered meals, people checking on you, a county case manager. And so the person would agree, I really need this stuff. And the case manager would send their name and contact information to the county. Done. Hospital evaluation complete. We solved the problem.
Uh-huh.
Except then the county would get it, try to call them back a couple days later. Do they answer their phone?
Nah, maybe.
Maybe, probably not, right? It's an unknown
Nobody
number.
answers their phone from an unidentified number anymore.
Yeah. And so we would put in all these referrals and they would go nowhere. So what we did, instead of the hospital case management team doing one thing and the county doing the other thing, we connected them and we actually took county case managers from where they were sitting in their office downtown and have them sit in the ER. So now they go to the patient's room, see them immediately, sign them up for services, and it's worked amazingly well.
So they sign them up for services on the spot in the emergency department.
Yeah.
Like,
And
can you give
how
me
did
some
you
examples,
get
like what
them-
services?
Sure. So we're a big county, with Columbus as the state capital. And so our county has a lot of older adult services. They will do medical or non-medical transport, home delivered meals. They'll help with utility payments, like if they're behind on their utility payments. The number of patients I have who I finally figure out that their water and electricity has been shut off and they're trying to live through that is too high to tell you. And they can also tell us if somebody already has a case manager or has an open adult protective services referral or how we can advance things. So one case we had was an older man who kept coming to the ER and he had cancer and he was always malnourished and cachectic. And then he'd be in the hospital for a few days and they would tank all the fluids and he'd go back home. Well, he had dementia and he wasn't living with anybody and he would forget that he had meals in the house. Or he would worry he was going to run out of food. So instead of eating his meals on wheels, he would hoard them and not eat anything and then call 911. So the county case manager said, well, we have him on weekly delivery. Why don't we change him to daily? So someone comes to his house daily, helps him prep a meal and eats with him. So he's eating every day. Stop the ER visits.
Yeah. And your article in JAGS has all of these great, like 5 case examples in a row that really help clarify for readers, like, this is how this can be useful in this real world clinical scenario. I also say it has great figures, as does the editorial by Liz Goldberg and colleagues. Lauren, I wanted to ask you, though, how on earth did you get these area resource aging people to come to the emergency department, to leave their desks in their office to get into the emergency department? Because that seems like monumental.
Yeah, it was. I had been working with their team for a long time. Every county in Ohio has an interdisciplinary elder protection team. So we meet monthly I'm the medical representative, and we also have people from legal, from police, from different social services who'll bring up cases. So it's really neat, and it's gotten me a chance to see how care outside the hospital happens. I mean, we feel like we do everything. We do everything for the patient. We're so good. But actually, we do such a minuscule amount of their care. And what these other community services are doing is providing so much more day-to-day support and keeping these people healthier than any medication change I've done from the hospital or ER.
I can also imagine, though, and I think you wrote about this in the JAGS piece, which we will have links to, both the editorial and the article on the show notes. But how did the hospital administration feel about this? Because, like, they're not privileged to do stuff in the hospital, these individuals, right?
Yeah. We had to be very careful to say that they are not providing clinical care. And initially, I wanted to get them electronic health record access so they could look and give us lists of like, oh, these people already have services, these people don't have services, but that was not allowed. So we had to be very clear about what's our hospital case management and social work team's job and what's the county care manager's job.
And Liz, when you read this article, because you wrote the editorial, did this surprise you? Did you say, oh my God, this is great? Like, how did you think about this? And is it applicable elsewhere? Like, can you imagine doing it in Colorado?
Yeah, I mean, first of all, it's a major, major implementation feat. One thing you should know about Lauren is she's this incredible dissemination and implementation scientist. And I think her knowledge in that area and in frameworks and how to bring teams together and what types of parties she would need to engage and strategies are a large part of the reason that this was successful. I think that's where a lot of these programs fail, is that you need a champion that is going to be doggedly pursuing this for their patients, regardless of the barriers and challenges you run into. And one of those things is, yeah, you're bringing an insider into a hospital. For us, that seems really simple. Here's your chair in the ED. Please, have a seat. But there's so many like regulatory, legal processes that go into play. And we've met those too, not only with kind of funding. Like, for instance, we have a social work embedded program here at UC Health, and part of their funding comes from outside county funds. So it doesn't come from clinical revenue per se. And just working through those challenges can be pretty significant, especially in health systems where they're academic affiliated, but the university sits on one side and the health system sits on the other side. So Lauren did a really nice job of describing sort of overcoming the hurdles that were there. But I do think every ED can do this. When I showed up here in Colorado, I moved about 3 years ago. I found out that community EDs that were part of our health system in our North region were running a version of GAPcare where they were having PTs and pharmacists see every falls patient on their own. They had read my manuscript and they had started the program. It was an IM doc that just had read this, thought it was great, and started it, had a dashboard. And it was this most amazing moment when I moved here. And I was like, oh, we can do this in the community. And this champion, who's really a clinician, doesn't get any academic buy down, was like, had bought into it and had put together this multidisciplinary group, and they had started it. And this is sort of what I love about emergency medicine is that, and I think we see this in other specialties as well, but people just realize to do the right thing for our patients, sometimes it takes more than just showing up for your shift. It takes like listening to what their concerns are, where the social needs are, where the other needs are, and convincing hospital leadership, convincing outside community partners, convincing your own colleagues that this is the right idea, and then measuring it and hopefully sharing that with others. So I think that's the model that we've been seeing in emergency medicine for the last 10 years with these embedded programs. And I'm just incredibly proud that we're able to launch these things. And Lauren's a perfect example of that.
And can I ask you, because I said I'd go back to GAPcare, I just want to clarify. So you have an older adult who comes in the emergency room with a fall. Does that like auto trigger a physical therapist and a pharmacist to see that person? Or is that...
So initially we did as a pilot. So our research staff would call the PTs, would call the pharmacists. But the way that it's running now within UC Health, thanks to our champion, Bucky Ferozen, who's a ED doc up north, is that they just have an automatic trigger when that chief complaint comes up for PT and pharmacy to see that patient. And the ED doc gets an OPA or a notice in their Epic. And they can say, this is not the appropriate patient to get PT pharmacy, maybe because that patient's going to get admitted and then they can get those services upstairs. We're really looking at helping people that are going to be discharged and going back to the community. And same thing with if they're coming from a nursing home, they're not great candidates for this. But yeah, it's an automatic trigger. And then it's a standardized workup that the pharmacists and the PTs do.
And can you say the outcomes one more time?
Yeah. So in our pilot trial, which was done at 2 EDs, 1 community, 1 academic, we saw that there was a 66% decrease in ED visits for falls within 6 months.
Oh.
And we also saw significant reductions in related hospitalizations in our second trial, which we're concluding now. So it looks like we're preventing serious falls, but also, any falls that are bringing folks to the ED. And it's because we're identifying reasons for that fall that the patient didn't even know. Like the amount of times that we've talked to the patient about their medications and found out they have 2 different prescribers, both which are prescribing pain medications or benzodiazepines and pain medications that's causing falls, or the amount of patients that PT has walked and like noticed that they have Parkinson's features and we've been able to get them, the diagnosis they need. Once you start to see the results, you become such a believer in the fact that we can do this feasibly in the ED and it's the right thing to do for patients.
That's great. And we don't have a link to the newer non-pilot data study yet because that's not yet published, though we can add that later. If Liz, you send it to us once it is published, we can add it to the show notes. But Liz, falls have been so hard to move the needle on. Like I'm sure you're familiar with Stride Study.
Yes.
We had a podcast with Tom Gill about that, and it's just so hard to move the needle. Maybe the emergency department is the best place to begin this, or one key location to begin this intervention? You think that's might be the major insight from your trial?
I think that's the question, right? With all these services we offer in the ED, we're like acutely aware that there might be actually a better setting to get those in. But the question is, does the patient actually make it to that better setting?
Yeah.
And in falls, what we know is that only 1 in 4 older adults actually report that they've had a fall to their primary care doctor in their annual wellness visit. So there's this great study by Hoffman et al. That showed that they're just not reporting it, maybe due to stigma, maybe they've forgotten. And so all these valuable prevention opportunities are being missed. So the idea is, while we have them in the ED, while they're actually engaged about like, why did this happen? And I never want this to happen again. What can I do to prevent it? That's when we can do these brief interventions with some, really actionable recommendations, like use your walker correctly,
Right.
or it turns out that you have a real mobility issue that we need to start working on. Let's get you some outpatient PT or home PT if you're homebound. So
that's a big
I don't know
contrast
that ED is only place to do it, but I think it's not happening elsewhere because people have challenges getting to other appointments. They already have 10 specialists that are caring for them, and they don't, they can't make it to another visit. So that's what we see in a lot of these falls trials, is that it just required a lot of momentum from that individual patient to get places and do things and coordinate. And that's where folks fall through the cracks.
Yeah. Yeah. And you're seeing the people who are most likely to benefit, who not only have fallen, this is an injurious fall. This has precipitated an emergency department visit. Like, this is serious. And like you said, they're motivated to change. Very different from the outpatient setting where you might ask, like, have you fallen? Oh, yeah, I think maybe a while back I fell. And then, okay, you're not as motivated. Maybe it wasn't an injurious fall. And Stride was able to reduce, as I recall, non-injurious falls, like overall any fall, but not injurious falls. So it's interesting that your study, you're reducing not only falls, but falls that result in ED visits and hospitalizations. That's terrific.
And I know
Eric, you got a question?
Oh,
go ahead.
Falls too, so I wanted to give her a chance to.
Oh yeah, Lauren.
Well, I think what Liz has done is very impactful, and I think it highlights that the ED visit is what you were just saying, Alex. It's a teachable moment. It's a moment when they're scared that something bad has happened, and so we can leverage that fear between them and the family and have a true falls discussion. I have an extensive family with many older adults, and none of them will admit to having actually fallen or be at falls risk, except for my mother-in-law who broke her arm falling, so she couldn't avoid that one. But I think we also know that if they see the physical therapist in the ED and get things started, they're more likely to follow up with them. And that's anecdotal, but we do have very low follow-up rates with physical therapy if we just put in a referral.
Yeah.
And I think there might be some bias against physical therapy in the older adult population because a lot of the people see it as painful or uncomfortable or, oh, you got to go so many times and you even get better. So having that moment where they realize, oh, this is not just for pain, they help with symptom control, definitely with injuries, but also with teaching. And they can teach me ways to prevent this from happening. A lot of people are very receptive to that.
Yeah, I see a lot of therapeutic nihilism. Physical therapy won't do anything. Until they actually start working with physical therapy. And then, hey, it's doing something.
So should everything be in the emergency department? Because it sounds like everything's better in the emergency. If you
move
get
all of our care to the emergency department.
This is a tough time to ask that, Alex. We're dealing with this crazy influenza strain and just boarding. So the amount of inpatients that are currently boarding in our ED hallways, boarding in our beds, emergency medicine is really at a critical point. And so I think Lauren and I, as like these geriatric champions, we have these discussions all the time with our colleagues about what more can we possibly do. We're already treating strokes, heart attacks, seeing people that have no health insurance and trying to, do our best by them, see people with all these social needs. So I think, there's limits on what we can do. And yet some of these programs are effective. So how can we not do them?
Yeah.
And I keep coming back to that. I keep coming back to the patients that I know that we've helped and we've done exit interviews with folks in our intervention and hearing from some of the folks that have been like in our control arm and haven't gotten that support and come home and they have they have a new humerus fracture. They are already walking with a walker. They are scared to go outside now because they have fear of falling and thinking, oh, all we're doing is x-rays and CTs. And in this short, 4-hour encounter, it can be hard to do more than that. But if we can bring in these professionals, we could really make a difference.
I
Lauren,
agree with
thoughts
that. I
on
think
the limits here. Like, how far can we go? Can we get everything in there? What pushback have you had about this, like from the administration or from others?
so. I think that we can show that bringing these interdisciplinary teams to the emergency department and starting the evaluations there helps the health system. It does avoid admissions. It does avoid readmissions. It can increase ER length of stay. So if that's a concern, then that can be addressed. When we originally started our program of multidisciplinary geriatric assessment in the emergency department, we ran it out of our OBS unit. And that way people didn't have concerns because they said, okay, we'll put them in. They can stay overnight and see PT, OT, geriatrics, case management, the pharmacist, and it's not our ED length of stay.
Yeah.
That's going to be affected.
But you, in your case, the first case you mentioned where the patient had dementia who had been readmitted, and they got admitted to the hospital for guardianship, like assigning a conservator, which is in California where we are, that's like a months-long process.
Yep.
And now that patient is in the hospital for months at a time, which is the right thing to do, and also incredibly expensive for the hospital if now you are uncovering cases such as this that fill up the hospital.
So when I proposed the county case manager program, that was one of my hospital administrators' question. You're going to fill up my hospital with patients that need placement and need support.
Yeah.
And so we said, okay, well, let's try it and we'll track it. And I think it's off balanced. We do identify some of these patients, but we also have systems in place to help them, including geriatric consultants, palliative medicine consultants, and Ohio State partners with the county. They have a guardian services board. So a lot of those patients who would in the past wait, honestly, 6 months to get a legal guardian placed are now getting a legal guardian within 3 to 6 weeks, which is amazing. So,
wow, that's great.
And that's something that other large counties can do too.
One other argument that we've made for these types of programs is that sometimes while you do increase ED length of stay, especially if you look at ED and observation care at the same time, when you front load this care in the ED or in the observation unit, you see less admissions overall and more eventual discharges. And things just happen more rapidly for us, at least here at UC Health, when we place them in the observation unit. And we have daily rounding of our case managers, PTs, and OTs. And we have specific geriatric order sets for those patients. We find that, yes, compared to previously, those patients have a longer ED length of stay, but then it cuts off 2 or 3 days of their hospitalization because we get them directly into SNF or into home care or into palliative care or into hospice directly from our observation unit instead of bringing them into the hospital and working this out over a series of days. So we have a specific no medical need for admission pathway within our ED here at UC Health. And so folks that were previously just admitted as a social admit, we couldn't arrange a safe discharge for them after a 3 or 4 hour ED stay. We instead now put them into the observation unit, bring in this multidisciplinary team, and we're way more successful at getting them what they need so they can go safely to home or to SNF.
Erica, let me ask one more question on this while we're on this thread. Liz, in your article, you wrote in your editorial that accompanied Lauren's paper in JAGS, you wrote about a concern about dumping. And I wonder if you could explain for our listeners what that is and whether that's a real world concern or more of a theoretical concern.
Yeah, and Lauren touched on this in her article too, but it's this perception by often hospital administration, but also other clinicians that once you create these suite of services that are really easy to access, patients just need to drop in whenever they want to the ED, right? They come at 11 p.m. if they want. Then maybe folks catch on at other hospitals and in the community, and then they start coming in on purpose to the ED because they know it's way easier to arrange if I go to the ED than to see my PCP or to go to this other hospital. I don't really know what to say about that.
Yeah.
I can't imagine that too many of our patients are like, I want to go to the emergency department now because it's so comfortable and fun and
And there's a
not
5-hour wait and filled with people with influenza.
Yes, and filled with people with influenza. So I have a hard time totally believing in that argument, but I have heard it. It's out there. I don't know what Lauren thinks.
I also don't think there are a bunch of 85-year-olds on Reddit saying, hey, go to OSU. You can't believe the care I got. If there are, thank you, but hasn't been an issue so far. I think one of our main issues is really doing better education on capacity, on social vulnerabilities for our older adult patients, because I see a lot of them going to other hospitals. And I've had people come to with notes or being told that, well, that hospital won't do capacity assessments, or they won't do legal guardianship, or they refuse to do this. And they shouldn't. Every hospital has the capability of doing all this.
How different is this from like geriatric EDs, or is this the same?
So the whole concept of a geriatric ED is still pretty nebulous. It's basically saying an emergency department that focuses on the different psychosocial and medical needs of older adults, and they can do it in different ways. So, as Liz described, the program in some of her community hospitals with pharmacists and physical therapists and case managers, that's a geriatric ED program or a geriatric ED intervention. Typically, they'll involve multidisciplinary staff, they'll involve medication management, but every one is slightly different, which makes it very hard to collate all the outcomes together. If you're considering doing meta-analyses on the topic.
But there's no like certification for like you have to meet like.
But I think there is. Right?
There
like
is
different levels.
Yeah,
There's
so
like
the
silver tier and bronze tier and gold tier. And
Exactly. So the American College of Emergency Physicians started certifying EDs as geriatric EDs, and I believe it was in 2019. And you had specific criteria that were in the bronze column, silver or gold. Gold is like you do everything. You make environmental changes to the ED, non-slip floors, grab bars, you have walkers to give out, and you also do these types of interventions like GAPcare or like Lauren's embedded social services. But every geriatric ED can choose among sort of a menu of different geriatric initiatives. They do want a physician and a nurse that are really great educators and champions in that area. It does cost some money for hospitals to get this certification. So some hospitals will do all the geriatric things, but won't go through a certification because of that cost, or because maybe there's not a lot of healthcare competition, so they don't really value putting that bronze badge out in front of their door. But many have gone through with that because they want to signal to patients in the community, like, we're here for you. We actually have specialized care for you. But you've seen one geriatric ED and you've seen one geriatric ED. They're all different.
I'm wondering, are there other programs that you see either around the US or internationally that you think, wow, like these are other really good examples of embedding into emergency department to improve the care of older adults?
Yeah, so I was very fortunate to spend 4 months in Australia last year on a Fulbright Award to Sydney, where I interviewed people from emergency departments all over Queensland and New South Wales. So those are two of the big territories, and learned what they were doing, which in many ways are far more advanced than what we're doing for older patients here.
Can you give me some examples?
Yeah, every single ED has a geriatric nurse who will help coordinate care. Many of them have whole interdisciplinary teams. I talked to one nurse out in this very rural, middle of the bush, tiny hospital, and she coordinated care for all the older adult patients, knows everybody in the community, would go out and see them in the nursing home or at their home after their ER visit and check on them, would arrange any social services they need. And if the patient comes into the ER, they will call the nursing facility or where they're from, get collateral from the family, make sure we're addressing all the families and the nursing facilities needs as well.
Well, is this because like everybody thought, hey, this is really good care? Or is there like a national or mandate like to do this type of care?
It was. So a group led by E.J. Marsden in Brisbane, did a pilot and said, hey, this really improves care. And so the government, remember, they have a national health system, said, okay, well, then let's do it everywhere. So they give every ED money to hire and start these programs. And we're talking to trainees, so residents, emergency medicine residents and faculty. I would say, so what would you do if the nurse is not there? Yeah. And they'd say, oh, well, we keep them till the morning till the nursing team is there and can help us with all this stuff. I was like, you don't just, in the U.S., most hospitals don't have these nurses and you just send them home. How would you do that? They wouldn't have everything they need. So it was amazing to see over just 5 or so years of having these care teams in every ER, how the culture has changed to recognize how important they are.
Liz, any examples from your perspective?
Yeah, I spent a lot of my childhood in Germany, and then I did medical school in Israel, which were both, had universal healthcare. And I will say, just reading over manuscripts from other countries, there's some really, really great work being done for our older adults. Wraparound services seem to be more robust in these countries where there's universal healthcare, where less fee for service, which makes a lot of sense to me. And so when I read those studies, when I review those studies, it does make me, hope that we can inch towards that with some of these programs that are being initiated just because it's the right thing for patients, but might not be well reimbursed at this point in time.
Mm-hmm.
So I think we have a long way to go.
Yeah.
All right. I know we got a long way to go. Oh, go ahead.
It gives us hope because when I talk to people, they say, oh, there's no way my hospital will ever do that, or that's way too hard. This is just routine care in many places around the world. We're the ones that are behind.
So let me ask you this, because my backup plan is I'm applying for a German citizenship. But just in case my backup plan fails.
It's true, dear listeners.
It is true.
He actually is doing that.
Like if you had a magic wand to make one change to get closer to kind of what you think the gold standard is, what would you use that magic wand on to change the care for these older adults? Lauren?
I think a way that we are headed towards disaster is our lack of home health care and home caregiving support. So if I could change something, I would change that, because then I would know when I send my patients back home, they would still get the care that they need.
Mm-hmm. Yeah, and it's that daily sort of care with activities of daily living that home health care would provide. Yeah. Thanks.
Liz?
I would try to break down the silos between some of these really fantastic community programs that are out there and health systems, so that if we identify risks in the ED, fall risk or other social risks, social determinants of health, it would be much easier to clearly communicate with those programs, link those people directly to those programs, and make some of this happen that hasn't been able to happen in the outpatient setting. But in the meantime, we'll continue our work in the ED.
But can I ask another question? Have you seen The Pit?
Yes.
Yes. Okay. How would you rate the quality of The Pit in terms of depiction of older adults, people with serious illness, the interactions they have?
What color are they in the geriatric ED? Bronze,
Are they
gold,
bronze tier?
platinum?
Yeah.
I think The Pit is very realistic in terms of what you may see in the typical ED in the United States. And
but no med student is doing what they're doing on The Pit.
No med student. I think the procedures are pretty awesome, and they're few and far between compared to the show, but it's otherwise really realistic in its depiction.
All right, Lauren, you agree with that one?
I honestly haven't seen it yet, so...
I've only watched a few episodes, but I was impressed. I did hear that they actually consulted with some experts in geriatrics and palliative care community. Have you heard that too?
I didn't hear that.
I knew
they have good ED docs advising them.
Yeah.
Okay, Alex, bring us home with some gravity.
All right, here's a little more. Let's see if I can stop playing.
I'll cut you off.
Oh, twice as much ain't twice as good, and can't sustain like one half could. It's wanting more that's gonna send me to my knees. Gravity, stay stay the hell away from me. And gravity has taken better men than me. Oh, how can that be? Just keep me where the light is. Just keep me where the light is. Keep me where the light is. Keep me where the light is.
Lovely. Lauren, Liz, thanks for being on this podcast.
Thank you so much for having us.
Yeah.
And we will have links to all the articles we talked about in our show notes. And thank you, listeners, for your continued support. We'd also like to do a brief shout out to those listeners who've donated more than $250, including
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordofsky, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Simoji, Matt Schuster, Carrie Hagan, Lloyd Woolstadt, Carrie Levy, Mamie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Nayak, Xinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, and Meg Walhagen.
your support keeps the microphones running, so thank you very much.